Hello, and welcome to FNP1. We will discuss ear disorders. Some statistics here about impaired hearing. So we have 10% of the population with impaired hearing, and 35% of this population are over 65 years of age. We also have 15% of school-age children with impaired hearing. Children with hearing impairment, they need to be identified by 3 months of age. With hearing assessment, from birth to 3 months, the baby should be startled with loud noise, awakened to sounds, and blinks to noise. From 3 to 6 months, the natural response is to be quiet to parents' voice, so when you're speaking, they stop to listen to new sounds. The baby should look for sources of sound and hopefully reciprocate when you're talking. By 6 to 12 months, they should be cooing, responding to simple phrases, turning to sounds, and responding to their name. By 12 to 18 months, the baby should be able to point to familiar objects when asked, follow simple directions, imitate sounds, and hopefully speak their first words. By 18 to 24 months, they should point to their body parts, and hopefully their vocabulary is up to 20 to 50 words. Tympanic membrane perforation can result from disease, especially infections, trauma, and be aware that perforations can be temporary or persistent. Infection is the main cause of tympanic membrane perforation. With traumatic perforations, this occurs from a blow to the ear, exposure to excessive water pressure. We see this quite a bit in scuba divers or patients that travel quite a bit in airplanes. Also for patients that attempt to remove wax, so patients that use Q-tips to try to remove wax or attempt to clean their ears. So to diagnose tympanic membrane perforation, you perform an otoscopy exam. So use your otoscope to look in the ear canal. And sometimes there might be some decreased hearing or ringing in the ear, so you may want to perform an audiogram. So the goal for medical treatment for perforations is controlling discharge that could arise as a result of the perforation. Just be aware to avoid any eardrops while there's an ear perforation. You may want to use some systemic antibiotics, especially if a patient has some discharge from the ear canal. It could be purulent discharge or not. And you may want to consider sending this patient out to the ENT specialist for further assessment. A good history taking is your first step to making a diagnosis. You want to know the nature of the hearing loss. Is it acute? Is it progressive? Or is it fluctuating? Is it in one ear or is it in both ears? You want to ask about associated symptoms. So is there any ear fullness, any pain, any vertigo, so dizziness, or tinnitus, ringing in the ears? You want to ask patient about some medications that they're taking. Of course, there are some medications that would result in hearing loss. Are there any recent hospitalization, surgeries, or any chronic illness? You also want to know about any family history of hearing loss and any recent trauma. On physical exam, you want to assess the ear canal. So the external auditory canal, you're looking out for any obstructions, any deformities, any trauma. And then with your otoscope, you want to look in the tympanic membrane for any fluid Any retraction? Is it intact? Or is there any Cholesteatoma, which is a cauliflower ear? And of course, you want to assess using your Weber and Riney test. And you want to look out for any anomalies. And of course, you want to perform a screening audiogram if necessary. There are two types of hearing loss. We have conductive hearing loss and sensorineural. We find that with conductive hearing loss, Weber testing shows that sound is louder in the affected ear. And with the Riney test, bone conduction is greater than air conduction. With the sensorineural hearing loss, we find that Weber tests sound is louder in the unaffected ear, and the Riney tests air conduction is greater than bone conduction. These are some of the differential diagnoses with conductive hearing loss. Otitis media is one of them. Otitis media with a fusion. There could be some cerumen impaction, so a lot of wax in the ears. There could be a foreign body. It could be chronic serous otitis, otitis externa, perforation of a TM, and otosclerosis. So you want to keep those in mind. Some differential diagnoses for sensorineural hearing loss are presbycusis. So this is hearing loss associated with age, noise-induced, drug-induced. So there are some medications that lead to hearing loss. Aspirin is one of them. Some beta blockers like metoprolol, and so on. Meniere's disease, acoustic neuroma, congenital sensorineural loss, acquired infections, and ototoxicity. These are some of the ways that we manage hearing loss in primary care. For conductive hearing loss, you want to remove any foreign bodies that may be present. You want to treat otitis, whether it's chronic or acute. Surgery could be performed for otosclerosis or any perforation of a tympanic membrane. Hearing aids could be used. And then for sensorineural loss, they're usually not correctable, so you want to let the patient know about this and really just having realistic expectations. For patients that have noise pollution or any noise exposure at work, they want to avoid occupational exposure. Educate them to wear earplugs. Surgery if there's acoustic neuroma. And you can discontinue any offending drug and see if this helps. All right, so when you've explored all your options, the treatment options that are available to you in primary care, consider referring the patient out to an ENT specialist or an audiologist. So also consider some health promotion activities that you could explore in primary care. So we talked about for sensorineural loss, you want to avoid any toxic drugs, so any offending drugs that may be causing this hearing loss. You want to make sure that you discontinue and see if this helps. Immunization is another way that we promote health. So MMR and influenza, make sure that you're giving patients their flu shot and they're up to date with your MMR shots. Treating prenatal and perinatal infections promptly could help to avoid congenital hearing loss. And also telling patients, especially those who work in chemical plants or in plants where they're exposed to noise pollution, to use protective equipment. And of course, for conductive hearing loss, you want to screen your high risk children. So this is a picture of an occluded external ear canal. So if you look, you can see a lot of earwax buildup, and this could cause some hearing loss. So be aware of that. Cerumen impaction is diagnosed by direct visualization with an otoscope. So you want to take a look in the ear canal and you find that there is a lot of wax. It could be unilateral, loss of hearing. The patient may complain of some fullness. There might be some itching. There might be some tinnitus, so ringing in the ears, or the patient may complain of dizziness. When performing a physical examination in adults with cerumen impaction, you want to be able to visualize the external auditory canal. So you pull the pinner gently upwards and backwards. And in your pediatric patients, the pinner should be pulled downwards and backwards. So be aware that impaction is light to yellow. Sometimes it's dark brown. It could present as a mass. And sometimes it prevents you from visualizing the tympanic membrane. So some differential diagnosis would be foreign body or otitis externa. So management of cerumen impaction, one of those would be removal. You definitely want to get rid of the wax buildup. So we typically would instill 2 to 3 drops of oil, and you can do that in a period of 3 to 5 days before coming in for a lavage. Docosate sodium, you can use that as well. And again, remember that we have a cerumen spoon if you are able to directly visualize the tympanic membrane. Of course, you do not want to perform an ear lavage either if an infection is suspected or if a patient has a history of tubes or if they've had surgeries in the ears. We also use over-the-counter D-Brox, and with that you can instill up to 10 drops of the solution in each ear canal and have the patient go to bed and wake up, and typically that takes care of the earwax. And then you can consider using some corticosporin otic solution, and that we use 4 drops 4 times a day for 7 days. So patient education, you want to make sure that you're telling your patients no Q-tips, because what happens with Q-tips is that the cerumen just gets impacted, and that's exactly what they're doing, just pushing the cerumen more and more into the ear canal. They can use 1 to 2 drops of oil every 1 to 2 weeks, or 1 to 2 times per week, and just let them know that they should not wear their hearing aids while sleeping. Otitis externa is an infection of the outer ear canal that leads to the tympanic membrane, usually due to bacterial infection such as strep or staph or Pseudomonas. Otitis externa is also called swimmer's ear, usually caused by excessive water exposure. It's typically superficial. It could be an inflammation or an infection of the external ear. And most times it's unilateral, so it's just on one side, and the patient complains of pain in the external auditory canal. The pathophysiology of otitis externa, trauma could be one of those. So patients that use Q-tips quite regularly, swimming, especially swimming in a lake or in dirty water, a staph infection, it could be Pseudomonas, Candida, or Aspergillus. So clinical presentation, again, unilateral pain in the ear canal. The patient may have some a feeling of fullness. They may have some itching, some pain. They may have tenderness of the tragus, which is the outer ear. They may have some mild lymphadenopathy and low-grade fever, even though that is not very common. So on physical exam, the patient will complain of pain with palpation, so touching the tragus. The patient may have some erythema or edema of the external canal. And the TM, the tympanic membrane, may be poorly visualized. And sometimes they may have some exudate in the auditory canal. So this is a picture of a patient with otitis externa. And you can take a look and see that the patient, the external auditory canal, the pinna, has a bit of redness going on and some edema going on. So you can imagine that palpating the patient's pinna would be pretty painful. And it looks like there's some exudate from the ear canal. These are some differential diagnoses that we find. Of course, your number one differential will be cerumen impaction. There could be some foreign body going on, especially for your pediatric patients. Malignant otitis externa is a possibility, so you want to keep that in your list of differentials. So how do we manage otitis externa? We want to be able to clean the ear canal, so you tell the patient to clean their ear canal, but not with Q-tips. They can just use some irrigation with 3% saline or hydrogen peroxide and do the cleaning. Needle drainage for a furuncle. So if you feel like, if you see and if you're comfortable doing the needle drainage, you can actually perform this for any furuncles or boils. A wick can be used for a narrowed canal. Typically, I will send this patient out to an ENT specialist for this purpose. So just be aware that for otitis externa, there is really no need for prescribing a systemic antibiotics. We typically would do the topical antibiotics drops. So corticosteroid, we use those quite a bit for drops. You can use that 3 to 4 times a day for 7 days. Decloxacillin, ciprofloxacin is another one that is fairly common, and we use that. If you're considering that there might be a fungal component, you may prescribe clotrimazole drops, ear drops. So remember your patient education. You want to tell the patient to dry their ears after swimming. What I have seen in primary care, I've seen especially for patients that are swimmers, long distance swimmers or competitive swimmers, I typically would let them know to use earplugs when they're swimming so they don't get water in their ears. And then no Q-tips. So again, remember to tell them that with Q-tips, they're just actually pushing in the cerumen right inside the ear canal and causing an impaction. And then they may use white vinegar with rubbing alcohol drops and 1 to 2 solution in each ear after swimming. So follow-ups are usually not necessary unless if the patient still has pain and symptoms 3 to 5 days after starting treatment. So we'll talk a little bit about chronic otitis externa. In this case, it's usually bilateral in both ears. It's painless. The patient will complain about pruritus, so a lot of itching going on. Stenosis or blunting of the ear canal, and you find a lot of ear fullness going on. So we'll talk a little about your acute otitis media in primary care. So the patient has an inflammation or an infection of the middle ear, which is different from your otitis externa, which is your outer ear. It could be a complication of an upper respiratory infection or allergies. With otitis media, we find that 94% of children with otitis media are age 2, and the most common indication for antibiotics. So for your patient with acute otitis media, typically you will prescribe a systemic antibiotic. 20% of otitis media are recurrent. Some risk factors for acute otitis media: being male, bottle propping, especially in your babies that are being bottle fed, exposure to an upper respiratory infection. Of course, a recent exposure to upper respiratory infection complication will be otitis media. Genetics, so we find some patients are just predisposed to otitis media. Caucasians and Native Americans. A patient that had maternal smoking, so the mom smoking when they were pregnant for the patient, or even just parental smoking. Allergies, a patient with abnormalities, the facial craniofacial abnormalities, or Down syndrome. So for acute otitis media, the pathophysiology could be as a result of a dysfunction of the eustachian tube, and that is right in the middle ear, cigarette smoke, and then we have some offending microorganisms, so strep pneumonia and H. influenza. Some clinical presentation that I found in acute otitis media include pain, especially with palpation, rhinorrhea, ear pulling, and this is found mostly in your pediatric patients. The patient might be irritable and just pulling their ears, and this is a cue for you to suspect otitis media. They may have some hearing loss going on. They may have a fullness in the ear, some popping and ringing in the ears. Vertigo might be another clinical presentation where the patient is dizzy. Lymphadenopathy, and the tympanic membrane could be gray to red. There could be some erythema going on. The patient might have some fluid in the ears, and it could be white in color. Some differential diagnosis: sinusitis, laryngitis, otitis externa, some serious otitis, your TMJ disorder. So you want to consider that as well as a differential. Mumps, the patient might be teething, so dental disorders. Tonsillitis is another differential. Ear trauma or foreign body. This is a picture of a patient with otitis media, so you can fully appreciate the tympanic membrane that is red, a lot of erythema going on, a lot of swelling. It looks pretty inflamed. So this would give you a cue that this is otitis media because it's right there in the middle ear. Management of acute otitis media includes prescribing systemic antibiotics. So we start with amoxicillin, especially with your patients without penicillin allergies, 500 milligram, and you can dose 3 times a day for 10 days. Remember that for your pediatric patients, you dose according to their weight. Amoxicillin clavulanate, which is augmentin, you can give those, especially if you're suspecting H. influenza and M. catarrhalis. Remember that the patient may have a lot of pain, so you can prescribe some Tylenol over the counter or ibuprofen. Nasal spray if a patient also has some rhinorrhea going on. Myringotomy is another procedure that we will send the patient out to an ENT specialist, and this is a surgical procedure that is used to create some incision in the eardrum to relieve pressure that is caused by excessive fluid buildup or pus in the middle ear. Or the patient can have some tubes inserted. So your pressure. Acute mastocytitis is associated with acute otitis media, and it's an infection that spreads beyond the mucosa of the middle ear and develops within the mastoid ear cell system. So the patients with acute mastocytitis have a lot of pain in their posterior ear. They may present with a fever. They may have some erythema, as shown in the picture, and they may have a swollen ear canal. So I want for you to be aware that with mastocytitis, there could be 5 stages. So the patient typically gets worse. The symptoms worsen. And despite the use of antibiotics, acute mastocytitis still remains a threat for patients with acute otitis media, and that's why IV antibiotics may be considered and the patient closely followed up. And also keep in mind that if unresolved, patient may need a surgical intervention. Serous otitis media is a collection of non-infected fluid in the middle ear space. It's also called otitis media with effusion. It is also a fluid buildup in the middle ear as a result of an upper respiratory infection. So with chronic serous otitis media, we have middle ear effusion greater than 3 months. The patient may complain of excessive mucus production or increased viscosity in the eustachian tube. And on your physical exam with your otoscope, you find that the patient has fluid stuck behind their tympanic membrane. Okay. Some risk factors for serous otitis media include patients that attend daycare and the number of hours they spend in daycare, exposure to children in home. So it could be an older sibling that has an infection and this could be transmitted that way. Smoking and the number of cigarette smokers in the house. Bottle propping. Your pediatric patients or your infants that are breastfed for less than 6 months. That's a risk factor. Autumn season, so change of weather. Early onset of acute otitis media. Several episodes of those. Bilateral otitis media with effusion is another risk factor. Patients with lower social economic status, that's another risk factor. And siblings with history of acute otitis media. So this picture gives you an idea of what serous effusion is, and you can see the fluid behind the TM. So pressure equalizing tube allows for drainage of entrapped purulent discharge or aeration of the middle ear and mastoid. It may sometimes allow topical antibiotics to enter the middle ear space. It's also used as a drain. And indication for pressure equalizing tube includes otitis media with effusion longer than 3 months, or patients with language delay, loss of hearing, severe retraction, recurrent otitis media, severe eustachian tube dysfunction, and complications of otitis media. This is a picture of a pressure equalizing tube, a PET tube. It's a very small tube which is inserted into the tympanic membrane by the ENT specialist. And the reason why we do that is to ventilate the middle ear and to treat and prevent middle ear infections. Cholesteatoma is an abnormal skin growth that can develop in the middle section of the ear, behind the tympanic membrane. It may be as a result of repeated middle ear infections or a birth defect. A cholesteatoma often develops as a cyst or sac that sheds layers of old skin. So it's a cyst of the middle ear or the mastoid. It may be congenital, like I had earlier mentioned, or acquired. Cholesteatomas could be as a result of chronic otitis with malodorous, purulent discharge. Patients may complain of vertigo, hearing loss, or facial nerve paralysis. So this is a picture of an acquired cholesteatoma, and you can see the growth, and this is the cyst that I earlier mentioned, and is sometimes called a cauliflower ear.